Next, a look at the opioid epidemic and alternatives for managing pain. The Senate health hearing included testimony from medical professionals and a patient advocate. It's just over 2 hours.
The Senate Committee on Health, Education, Labor, and Pensions will please come to order. Senator Murray and I will each have an opening statement, and then we'll introduce witnesses. After their testimony, senators will each have a 5-minute round of questions. Dan, who is a constituent of mine in Maryville, Tennessee, recently wrote me about his wife who has a rare disease that causes chronic pain. Dan's concerned because it has become more difficult for her to access painkillers. This is what Dan wrote, quote, "She's not an abuser and is doing everything right. Now it's harder for her to get the medicine she needs," unquote. Dan's wife is one of 100 million Americans who, according to a 2011 report by what is now the National Academy of Medicine, are living with some pain. That's about 30% of Americans. 25 million of those, the Academy said, have moderate to severe pain. A new report in 2018 by the Center for Disease Control and Prevention says about 50 million Americans have chronic pain. Nearly 20 million of those Americans have high-impact chronic pain. Now, here's the reality. We are engaged in a massive bipartisan effort to make dramatic reductions in the supply and use of opioids, which is the most effective painkiller that we have. But on the theory that every action has an unintended consequence, we want to make sure that as we deal with the opioid crisis, that we keep in mind those Americans who are hurting. We're holding this hearing to better understand the causes of pain, how we can improve care for patients with pain, and where we are on developing new medicines and ways to treat pain. We know that pain is one of the most frequent reasons that people see a doctor, and according to the Mayo Clinic, the number of adults in the United States with pain is higher than the number of people with diabetes, heart disease, and cancer combined. These Americans need more effective ways than opioids or other addictive painkillers to manage pain. Opioids, which are commonly used to treat pain, can lead to addiction and overuse. We know that well. More than 70,000 Americans died from drug overdoses last year, including prescription opioids, making it the biggest public health crisis in our country, affecting nearly every community. Last year, in the midst of the acrimony of the Kavanaugh hearing, Congress and another part of the Capitol saw 72 different senators, or 70 senators offering 72 different suggestions for a comprehensive opioid legislation, which passed the Congress and which President Trump signed and called the largest single bill to combat a drug crisis in the history of our country. That legislation from all those senators included 8 committees in the House and 5 in the Senate. It included reauthorizing training program for doctors and nurses who prescribe treatments for pain, increasing access to behavioral and mental health providers, encouraging the use of blister packs for opioids such as 3 or 7 day supply, and safe ways of disposing unused drugs. We also took steps to ensure our new law wouldn't make life harder for patients with pain, but now we need to take the next step to find new ways to help them. First, we gave the National Institutes of Health more flexibility and authority to spur research and development of new non-addictive painkillers. We also asked the Food and Drug Administration to provide guidance for those developing new non-addictive painkillers to help get them to patients more quickly. I'm pleased to see Commissioner Gottlieb's announcement this morning that the agency is developing new guidances on how FDA evaluates the risks and the benefits of new opioid treatments for patients with pain, and to help the development of non-opioid treatments for pain. Sam Quinones, a witness at one of our hearings, called new non-addictive painkillers the, quote, holy grail to solving the opioid crisis. We've backed up those new authorities with substantial funding, most recently $500 million to help the National Institutes of Health find a new non-addictive painkiller. Second, we included provisions to encourage new pain management strategies such as physical therapy. And third, the new law requires experts to study chronic pain and report to the director of the National Institutes of Health how patients can better manage their pain. And fourth, the new law requires the Secretary of Health and Human Services to report the impact on pain patients that federal and state laws and regulations that limit the length, quantity, and dosage of opioid prescriptions. Now that we've started to turn the train around and head in a direction that is different on the use of opioids, every one of us, doctors, nurses, insurers, patients, senators, congressmen, will need to think about the different ways we treat and manage pain. There are other things the federal government is doing to understand what causes pain and how we treat and manage it. For example, the National Pain Strategy, developed by the Interagency Pain Research Coordinating Committee, which develops recommendations to prevent, treat, manage, and research pain. Through the National Institute on Drug Abuse and the National Institutes of Health's HEAL initiative, researchers are working to better understand pain and why some people experience it differently than others. This will help us find more ways to more effectively treat pain and help get people the treatment they need. For example, physical therapy or exercise may be the best course of treatment for some kinds of back pain. It may also help us understand why some people can take opioids or manage their pain for years without becoming addicted, while others more easily become addicted. Today, I hope to hear more about how close we are to having non-addictive painkillers and how doctors and nurses can better treat Americans who live with pain. Senator Murray.
Well, thank you very much, Mr. Chairman, and thank you to all of our witnesses for joining us today. This committee has done a lot of important work on the opioid crisis that families and communities across the country are facing. I was glad we were able to come together last year to take strong bipartisan steps to address some of the root causes and ripple effects of the opioid crisis. I hope we can continue to build on that work. However, today's hearing does offer an important opportunity to take a slightly different perspective on some of the challenges related to the use of opioids. And I hope it can serve as a reminder that while we are working to address substance use disorder and help the families facing it, we can't forget about the people who are facing pain, both acute and chronic. And we cannot overlook how important it is they get the tools they need to manage their pain and find relief. For too long, providers were incentivized to think of opioids as an easy and harmless solution to addressing pain. And the lack of understanding about pain management and the risks of opioid prescribing meant healthcare providers prescribed opioids far more often than was necessary, contributing to the tragic increase in opioid misuse. But that doesn't mean the solution to the opioid crisis is for providers to stop finding ways to help their patients manage pain. We have to find responsible, comprehensive solutions for pain management that ensures opioids are marketed, prescribed, and used responsibly, but at the same time are within reach for people dealing with chronic pain. It's important to remember that for many people who are elderly, people who have been seriously injured, people with chronic health conditions or undergoing aggressive health treatments, and people who have a disability. Pain seriously impacts their day-to-day lives. 50 million people nationwide suffer from pain that persists for weeks or even years. For almost 20 million people, this pain can interfere with their work and daily life activities. Pain management is an absolutely critical quality of life issue for these people and their families. Acute and chronic pain can make it harder to keep a job and earn a paycheck. Even when treated, pain can make it difficult to travel to and from work and sit at a desk for long stretches of time. And pain doesn't just affect a person's livelihood, it affects every aspect of their life. Without pain management, patients may not be able to tackle the tasks they need to live independently, like getting dressed or driving a car or doing laundry. They may not be able to spend quality time with their loved ones, as their pain can make it hard to enjoy a meal with friends or family, or attend a grandkid's soccer game, or even leave the house. Without the right pain management tools, some patients struggle to get a decent night's sleep. For people living with pain, the ability to get treatments that help them manage it can impact their entire life. And I'm very interested to hear from one of our witnesses today to offer her firsthand perspective on this. We appreciate your being here. It is so important we listen to patients about their healthcare needs, whether that is finding ways to address that person's pain or recognizing when asking for painkillers is a result of an addiction, which requires an entirely different form of treatment. Of course, another part of what makes this issue so challenging is that no two people experience pain the same way. Where pain is felt, how severe it is, how long it lasts, and how much it impacts their life can vary widely from person to person. Pain is not a one-size-fits-all, and the tools we use to manage it cannot be either. We need to do more to make sure everyone facing pain is able to get treatment that works for them. This means ensuring research is done to better understand the biological basis of pain and the factors that determine what might work best for a patient. It means training providers to recognize pain symptoms, to truly listen to their patients' needs, and to consider lower risk, less invasive options before turning to more extreme measures. And it means making sure insurers' policies support access to these options rather than incentivizing providers to simply write a prescription for an opioid without taking the time to understand what might work best for that patient. And for some with severe pain, it may mean responsible opioid prescribing, but for many others, there are options that will work better and have lower risks of addiction. From other types of drugs that might fit better their needs, to services like physical therapy, to treatments that help address the psychosocial dynamics of pain, like cognitive behavioral therapy, to support for modifying their lifestyles in ways that might help manage their pain, like through exercise. And it means addressing threats to their healthcare, like the blatantly partisan legal threat from the Republican lawsuit that could strike down protections for people with pre-existing conditions, including people affected by pain. During our hearing today, I'm interested to see what insight our witnesses have to offer about these very complex problems and what steps we can take to help people get the support they need to manage their pain. For example, what can we do to make sure insurers cover pain management options that patients need and do so in ways that help them quickly find the treatment that works best for them? How can we tackle the workforce shortage and make sure people in pain are able to find a care provider that can serve them close to their home? What can we do to address health disparities when it comes to pain treatment? And how can we make sure employers understand their obligations to accommodate employees struggling with chronic pain under the Americans with Disabilities Act and help them learn how best to support those employees? As we continue our efforts to respond to this opioid crisis and build on the strong bipartisan steps we took last year, I'm really glad that we have this opportunity to take a look at another very important angle of this challenge. So thank you, Ms. Speaker.
Thank you, Senator Murray, and thanks to you and to your staff for working to create this bipartisan hearing, which is an important follow-up to our work on the opioids bill last year. Each witness will have up to 5 minutes for his or her testimony. We welcome each of you and thank you for coming. Our first witness is Cindy Steinberg. She's the National Director of Policy and Advocacy at the U.S. Pain Foundation and Chair of the Policy Council of the Massachusetts Pain Initiative. She was appointed in May 2018 by the Secretary of the Department of Health and Human Services to serve on the Pain Management Best Practices Interagency Task Force, and she previously served on the Interagency Pain Research Coordinating Committee of the National Institutes of Health. Senator Smith, would you like to introduce the next witness?
Thank you, Chair Alexander. I am really honored today to introduce Dr. Gazelka from my home state of Minnesota. Dr. Gazelka's work represents the healthcare innovation that is happening in Minnesota and at Mayo Clinic. Dr. Gazelka is the Director of Inpatient Pain Services in the Division of Pain Medicine at Mayo Clinic in Rochester. And she is also an Assistant Professor of Anesthesiology at the Mayo Clinic College of Medicine. And she has dedicated her professional life to pain medicine and palliative medicine. Dr. Gazelka has worked extensively in opioid management as well as acute and chronic pain management. And most recently, she was appointed by HHH Secretary Alex Azar to serve on the Pain Management Best Practices Interagency Task Force, a mouthful and very important work. Dr. Gazelka attended the University of Minnesota Medical School and completed her residency and fellowships at Mayo Clinic College of Medicine. And I think that her professional experience makes her perfectly suited to testify before us today on pain management with this opioid crisis in front of us. And I know that we're all going to benefit from your expertise. So thank you so much, Dr. Gazelka, and thank you for taking time away from your practice and your patients to be with us today.
Thanks, Senator Smith. Dr. Andrew Koop is the next witness, Professor and Associate Dean for Academic Affairs at the University of Maryland School of Pharmacy. He's currently researching a new opioid analgesic that may have less potential for abuse and diversion. And finally, Senator Burr, would you introduce our remaining witness?
Mr. Chairman, thank you for holding this very important hearing. I welcome all our witnesses today. And I have the great pleasure, Mr. Chairman, for the opportunity to introduce Dr. Anu Rayo Patel from Durham, North Carolina. In her current role as lead medical director at Blue Cross Blue Shield of North Carolina, Dr. Rayo Patel is responsible for making coverage decisions for healthcare services and prescription drugs for a number of health benefit plans offered by North Carolina Blue Cross. She's also spent much of her career treating patients with chronic and painful conditions such as lower back pain and migraine headaches. Dr. Rayo Patel is board certified in physical medicine and rehabilitation, active member of the American Academy of Physical Medicine and Rehabilitation and the American Medical Association. Before moving to North Carolina, Dr. Rayo Patel received her medical training and medical degree from Louisiana State University. She completed her internship in internal medicine at Earl K. Long Hospital in Baton Rouge and residency training in physical medicine and rehabilitation at Sinai Hospital, University of Maryland in Baltimore. I was overly impressed with her background until I found out that her attending physician in her internship was Dr. Cassidy.
You thought better then, huh?
I do know that she had a hard charging attending as she went through that internship. Dr. Rayo Patel, thank you for all the important work you do on behalf of North Carolina. I look forward to hearing your testimony before the committee today on how we approach pain management in North Carolina during a very devastating time of opioid crisis in this country.
Dr. Cassidy, do you have any comment on your former resident?
It's so gratifying to see someone who's a former student do so well. And so I'm incredibly proud that you're here. So I'll just limit it at that.
Thank you, Senator Cassidy and Senator Burr. Now, why don't we begin with Ms. Steinberg, and if each of you would summarize your remarks in about 5 minutes, we'll go right down the line. Ms. Steinberg, welcome.
Thank you. Thank you for your introduction, and thanks for holding this hearing on a really important issue in pain management. It's a conversation that's long overdue. My life changed in an instant more than 2 decades ago when I was crushed in a serious accident that left me with severe back pain that has never gone away. On an otherwise typical day at my job as a manager at a technology company, I opened my file drawer and unbeknownst to me, moving men had stacked cubicle walls against it. The cabinet and all the walls fell on me, crushing me and causing extensive damage to my back and spine. I was suddenly plunged into a search for relief from an unrelenting, gnawing, burning band of hot coals across my mid-back and the crushing pressure of clenched muscle spasms. Chronic pain is very different from acute pain. It is relentless. It never ends. I often say it feels like you are a prisoner in your own body, only you're a prisoner being tortured 24/7 and there's no escape. After a discouraging, difficult, and at times demeaning 5-year journey of searching for help while trying to hold on to the career that I loved, I finally found a doctor who helped me. Even so, the pain eventually forced me to give up my career. Out of my sense of loss and isolation, I decided to start a support group for others living with chronic pain. I was shocked at how many people started showing up for monthly meetings, all ages, men and women, all backgrounds. 18 years later, I'm still running that group, and more than 400 people have come to this group in a suburb of Boston. I learned that my story is everyone's story with pain in America. Though the causes of pain vary, each of us has had the same experience of struggling to find adequate care. Everyone had to see 4 or 5 practitioners and gone through years of discouraging and expensive trial and error treatments before they could find help. The scope of chronic pain is enormous. The number of Americans impacted by pain and the human suffering involved and the cost of the healthcare system and society is staggering. You've said some of these things yourself. 50 million Americans live with chronic pain. 20 million have high impact chronic pain, which is pain that affects their ability to work, live, socialize on a daily basis. Pain is the number one reason why Americans access the healthcare system. It is the leading cause of disability in the United States. Pain costs our economy $600 billion a year in lost productivity and direct medical costs. Despite the impact of pain, we've failed as a country to effectively address it. We've underinvested in pain research relative to its burden. Less than 2% of the NIH's annual budget has gone to pain research. We still do not understand the basic neurobiological mechanism of pain in the human body. Medical students receive an average of 9 hours of pain management training in 4 years. Veterinarians get 87 hours. Your pet is getting better pain management often than people do. And less than 1% of physicians are specialized in pain management. In the midst of the opioid crisis, there has never been a more important time for policymakers to improve pain management. Some well-intentioned measures to contain the crisis have resulted in unintended consequences for chronic pain patients. We and other groups have heard from thousands of chronic pain patients who have been forcibly tapered off their medications or dropped from care completely by their doctors. This is inhumane and morally reprehensible. Opioids are one treatment among many. They should not be a first-line treatment for chronic pain. Patients and providers must work together closely to carefully balance benefits and risks for each person. Nevertheless, for many pain sufferers, particularly those with severe pain, opioids can be a lifeline to lessening their pain. In the near term, we can and must restore balance to opioid prescribing. In the long term, we must invest in the discovery of new, effective, and safer options for people living with pain. There are, however, many steps we can take now to give people with chronic pain the quality of care they so desperately need and deserve. Some examples include reducing insurance cover barriers to ensure that a full range of pharmacological and non-pharmacological treatments, including complementary treatments and medical devices and technology. Promoting reimbursement models that encourage providers to dedicate the time and resources necessary to treat the complexities of pain, promoting individualized integrative multi-care plans, investing in vital collection and reporting of epidemiological data on pain, increasing research into understanding pain in the human body, and investing in ongoing patient support and teaching of self-management skills for living with a chronic illness. Fortunately, Congress has an excellent policy blueprint for implementing these measures, and that blueprint is the report of the task force that you have mentioned. That report is due out in May, and it has many excellent suggestions that I hope you'll implement. Thank you.
Thank you so much, Ms. Steinberg, for making the trip and for being here today. Dr. Gazelka, welcome.
Thank you. Chairman Alexander, Ranking Member Murray, and members of the committee, thank you for allowing me to testify today. My name is Helena Gazelka. I'm an anesthesiologist practicing pain medicine at the Mayo Clinic in Rochester, Minnesota. Mayo Clinic cares for more than 1.3 million patients annually from all 50 states and from over 140 countries. The needs of our patients range from primary care to very complex and serious conditions. I'm honored to serve those in need of both acute and chronic pain care and palliative care. I'm privileged to share my insight as a provider and a leader in an organization that is thoughtfully addressing the pain management needs of our patients. Pain management is, at its essence, individualized medicine. No patient is the same as another, and therefore each condition, treatment, and surgery has a unique impact with relation to pain. To ensure that patients receive appropriate pain treatment, Mayo Clinic created the Opioid Stewardship Program in 2016, which I chair. Through these efforts, we realized a dramatic reduction in the amount of opioids provided to our patients. Our program evaluated surgical specialties, and we surveyed thousands of patients to develop internal prescribing guidelines. But they're not a replacement for clinical judgment. Using these guidelines, some of our departments have realized a reduction in opioid prescribing of up to 50%, all while maintaining a high level of patient satisfaction. The goal is not only to provide the best care at Mayo, but to share our work with others. Our experience has helped other healthcare organizations improve their pain management, reduce opioid-related morbidity, and decrease diversion. Established in 1974 in Rochester, Mayo Clinic's pain rehabilitation program has helped bring hope and management strategies to thousands with chronic pain over the past 4 decades. Similar centers have been established at our Florida and Arizona practices. While pain rehab is very effective, insurance coverage for it is limited. For instance, it is covered by Medicare, but not by Medicaid. Today, I'd like to convey 4 key points to you. First, dose limits on opioids, such as 3- and 7-day limits, will not satisfy the acute pain requirements for patients equally. Patients and procedures vary significantly. A patient recovering from the removal of their wisdom teeth will have a very different pain management requirement than a patient recovering from a major orthopedic surgery or a trauma. These variations are the basis for our procedure-specific and patient-specific guidelines. Chronic pain lasting for months to years typically could be related to cancer or could be as common as back pain, for example. As the condition and the needs evolve, physicians should utilize evidence-based interventions, medical therapy, and restorative therapies to ensure proper management. Typically, patients with chronic pain, particularly when it's not cancer-related, may be better candidates for non-opioid therapies. An individualized approach to care is paramount, and policy should promote the use of effective non-opioid treatments. Further research is needed to determine why some patients with acute pain develop chronic painful conditions and to find a means to interrupt that progression. Secondly, federal policy should embrace multifaceted approaches to the treatment of opioid use disorder, including access and prevention. Medicare and Medicaid must develop additional coverage of and reimbursement for non-opioid pharmacotherapies and treatment regimens for chronic pain to prevent the contact with opioids that may ultimately lead to addiction. Particularly for chronic pain, where little medical evidence exists in support of long-term opioid use, other solutions to manage pain may be cost prohibitive, time-consuming, and lack appropriate coverage by insurers. The basis of chronic pain management was focused on treating the whole individual with restorative, behavioral, psychosocial, and medical and procedural elements combined appropriately to the patient and the condition. There's not only a paucity of pain management providers and resources, but in cases where opioid use disorder does complicate management, not enough treatment programs exist to satisfy that need. Third, the optimization and standardization of prescription drug monitoring programs should be pursued. While most states currently utilize them, the existing programs are varied and the administrative burden is additive. Nationally, there's a greater need for coordination and consistency across the PDMPs. Finally, we believe that empowering patients is a major key to solving the epidemic. We must increasingly engage patients in shared decision-making and educate them on treatment, risks, and alternatives. We also believe the role of communities and local governments are important. Because opioids provided legitimately by providers are only one facet of this problem, the epidemic will only be solved with a collective approach. Thank you for the opportunity to join you today and for your efforts in ensuring proper pain management amidst the opioid crisis. I'm happy to answer any questions.
Thank you, Dr. Gazelka. Dr. Cook, welcome.
Chairman Alexander, Ranking Member Murray, and committee members, I thank you for the opportunity to testify today. My name is Andy Coop. I am the Associate Dean for Academic Affairs at the University of Maryland School of Pharmacy. But I'm a chemist. I make new drugs. I was trained over the pond by a guy called John Lewis, who many people have forgotten about. He was the guy who discovered buprenorphine. He trained me that academics are here to make discoveries, but unless those biomedical discoveries are translated to the patient, it's all for nothing. I applaud the federal funding agencies for their focus on translational research. As we've heard, chronic pain is horrendous. There are figures, there are dollars out there, but we just owe everybody a better solution. They are a wonderful, outstanding class of opioids, and we should ensure that patients that require opioids get them. But we need to respect them. It's like a big dog. We need to respect them. But I've been asked today about the new analgesics coming down the pipeline, including, in full disclosure, the compound I'm working on. So opioids, not opioids. There are lots of other options, but what about opioids? Well, first of all, we need to define what we're talking about. If we don't define where we're trying to get, we're never going to get there, which is the reason I do not use the word addiction. It is very hard to define on biological mechanisms. I use the terms dependence and reinforcement. The two concepts need to be solved when we're developing new opioid medications. Okay, what are they? Dependence is when you chronically take a drug, your body adapts so it becomes normal to have the drug present. You stop taking it, you go into withdrawal. There's only one surefire way of eliminating withdrawal, and that's taking more drug. That happens in the clinic to patients. Reinforcement is the high. Taking a drug recreationally, it's acute, it's instant, you get high from taking the drug. So recreational seeking of a drug is seeking to get the high. Long-term, chronic is the dependence. They are two very different concepts. We need to address both. So, sorry, I've got ahead of myself, sorry. We need to solve both. If we think about abuse deterrent formulations, they are designed so that they cannot be abused on the street. They're used in the clinic. That's great. They will not be diverted, but they will still cause dependence. So discontinuation would still cause withdrawal. So what's being done towards these areas? We have biased agonists, which is activating one pathway, not another. We have approaches where opioids only go to one place in the body. We have what I am doing, and many others, as many people doing this, where we actually target two biological systems, where the second biological system modulates the first to prevent the dependence and the reinforcement. Many are in development in both academic and industrial laboratories, and it's important to continue this funding, of which, thankfully, NIDA and the NIH have been wonderful. We need that consistent funding. As mentioned by the chairman, the FDA has a critical role in addressing these drugs, but not only does the FDA need to do this rapidly, it needs to be safe. It's safe and effective. We need to ensure that we don't bring drugs to the market that make things worse. Non-opioid medications, we have gone through some of these, some that weren't mentioned. OTC, ibuprofen often works very well for many patients, and we need to remember that. We have local anesthetics, we have channel blockers, we have capsaicins, the non-pharmacological treatments. And yes, we need to do further research, and yes, it's controversial, but we really should look at the potential of cannabinoids. The studies are not out there. If we don't have the studies, we cannot make the decision on the potential of cannabinoids. In my last 2 minutes, I just want to talk quickly about my profession of pharmacy, my doctored profession of pharmacy. Pharmacists pretty much often get ignored in this crisis. They are accessible, they are trained, they are doctors. They are able to help with counseling patients on the appropriate medications to use. And one major impact that the federal government could make is to expand the prescribing of buprenorphine for medication-assisted treatment to include pharmacists. This is called getting a data waiver, so that the pharmacists, under a collaboration, could prescribe buprenorphine and provide the buprenorphine in a very accessible pharmacy. Thank you.
Thank you, Dr. Cook. Dr. Rayo Patel, welcome.
Thank you. Good morning. Thank you, Chairman Alexander, Ranking Member Murray, the distinguished members of the committee, their staff, for providing me the opportunity today to talk about the management of pain during the opioid crisis. Apologize. My name is Anu Rao Patel. I'm a lead medical director at Blue Cross Blue Shield of North Carolina. My background is in physical medicine and rehabilitation, and prior to joining Blue Cross 4 years ago, I was in private practice doing chronic pain management and some management of addiction. I continue to remain clinically active. I see patients regularly in addition to my primary role at Blue Cross. I hope to provide unique perspective today to the committee based on my clinical training and practice as a board-certified physiatrist, my firsthand management of chronic pain, as well as my perspective as a medical director at Blue Cross North Carolina. I've also submitted written testimony which further expands on my comments. At Blue Cross North Carolina, we serve close to 4 million customers. We're in every zip code of all 100 counties. The Blue Cross North Carolina PPO network of healthcare providers includes 96% of medical doctors and 99% of general acute care hospitals. Blue Cross North Carolina is accredited by the National Committee for Quality Assurance. We're all aware of the scope of the issues with the opioid crisis, both the human and the financial toll that it's having. In North Carolina alone, Attorney General Josh Stein stated that in 2018, 4 people died every day from an overdose, and that between 2017 and 2018, the number of fatal overdoses in North Carolina increased by 33%, and that is even with efforts to reduce overdose deaths by distributing naloxone to reverse narcotic effects. Blue Cross and Blue Shield companies are strongly committed in doing our part to combat the epidemic of opioid use disorder while ensuring patients living with chronic pain get access to appropriate evidence-based treatments. As evidence of this unified commitment, I'm listing several examples of things that we cover. We provide coverage for non-opioid pharmacologic alternatives for pain management, including nonsteroidal anti-inflammatories, antidepressants, anticonvulsants, topical analgesics, alpha-2 agonists, and others. We provide coverage for non-pharmacologic alternatives for pain, including physical therapy, occupational therapy, aquatic therapy, chiropractic care, trigger point injections, biofeedback, steroid joint injections, interventional pain procedures, including facet blocks, medial branch blocks, epidural steroid injections, spinal cord stimulators. We cover TENS units, intra-articular hyaluronic acid injections for knee osteoarthritis, Botox injections for migraine and spasticity, as well as others. We have endorsed the CDC guidelines for prescribing opioids for chronic pain, and we're working collaboratively with the prescriber community to implement these, understanding that there is not a one-size-fits-all approach to managing pain. We support access to medication-assisted therapy, including the associated counseling and behavioral therapy. We support a wide availability of naloxone. We support enhanced operability of prescription drug monitoring systems and encourage providers to access this data before prescribing. As chronic pain is a legitimate and debilitating medical issue, there are many opportunities for physicians to continue to manage pain effectively with or without the use of opioids. Physicians must incorporate universal precautions in the use of pain medicine for the treatment of chronic pain, including making an accurate diagnosis, informed consent with the patient, treatment agreements, pre- and post-intervention assessment to assess pain and function. The goal of long-term pain management is to support the patient in improvement of their function and quality of life as much as possible, despite their ongoing pain symptoms. Opioids are certainly an option to support select patients in managing symptoms and should be prescribed thoughtfully and judiciously as part of a broader pain management regimen. In addition, patients must have realistic and honest expectations of pain management goals, including understanding that in certain circumstances, elimination of pain in its entirety is not a possibility, but certainly a goal. Providers should continue self-education on appropriate prescribing and in pain management, as well as participation in their state and medical licensing boards on continuing medical education requirements. There must also be increased training in medical school and residency programs on pain, as well as addiction, as well as increased research nationally on pain. Finally, physicians and payers must understand, as mentioned several times, that there is no one-size-fits-all approach to manage chronic pain. It must incorporate a holistic, multimodal, and thoughtful approach similar to any other chronic medical condition. Thank you again for including me in this discussion. Blue Cross Blue Shield companies share your commitment in addressing America's opioid crisis and ensuring those who are suffering from opioid use disorder as well as chronic pain get the care that they need. Thank you.
Thank you, Dr. Rao Patel. We'll now go to a 5-minute round of questions. I'm going to try to hold the combined questions and answers to 5 minutes because we have lots of senators interested in discussion today. I'll begin with Senator Isaacson.
Thank you, Chairman Alexander. Ms. Steinberg, I hate to make you get up off your cot.
That's okay. I'm used to going back and forth.
Well, you can tell that you have the problem we're talking about, and we appreciate all you're doing to help us learn more about it. And Dr. Coop, I appreciate your pronunciation, all those words. I can't pronounce any of them. And I'd like to know what the name of the new one have you named the new one you're working on?
It's got a code number at the moment, UMB 425.
Okay, well, that doesn't help me much.
No.
I do numbers better than letters anyway, so thank you. But thanks to all of you. I lost a grandson to an overdose and an addiction. And so this issue is important to me. And so much of the stuff that's on the streets now is stuff gotten out of medicine cabinets and homes. And it may have come from Mexico. It may have come from Canada. It may have come from somewhere else, but kids got in a medicine cabinet and took them and it caused big problems. My first question, Dr. Patel, maybe you'd be the best person to ask this, or probably all of you would be, what is hydrocodone the most prescribed? Is it the most prescribed pain medicine?
Yes, it is.
It's an opioid, is it not? Yes. The reason I asked that question is I had a major back operation 2 years ago. I mean, major pain. And the surgery worked. I had to finally go to surgery and have fusion and all that kind of stuff. But I noticed that I was always getting hydrocodone because I was having dental work done in terms of implants. I was having a back surge fusion done, and I got so much hydrocodone, it just seemed like I had an excess of it. Is it prescribed more than anything else because it's less addictive than other types of opioid-based pain medicines, or is it just the most popular one?
You want to answer that?
I think that's probably a culture. It's a very popular medication because it's always been combined with acetaminophen. And so people have felt that perhaps you would need less opioid with the combination of acetaminophen. It's been sort of a culture in dental schools and other outpatient arenas, particularly to prescribe hydrocodone.
Well, it's equally as addictive, is it not?
It is, yes.
But one of you, and I forgot who did it, so all of you can address this question, but one of you talked about addiction. And I think that's the problem. I mean, and you talked about encouraging new development. I think, Ms. Gazelka, you said that by the pharmaceutical companies and others to find replacements for opioid-based painkillers and to help with the problem. I think that's exactly it. I mean, I think that if we could take all the hydrocodone that's prescribed in America and substitute some new development for it that doesn't use opioids as a base, we'd solve a lot of our problems on addiction, I think. Do you know how many the pharmaceutical companies are actually working on something like that? And maybe what Dr. Coop's working on, I don't know, but is there a lot of work being focused on trying to find a replacement for that?
I have a list actually here of about 12 different laboratories currently working towards new opioids. But that's just on the opioid space. They're also working on the non-opioid space.
Yeah, the replacement.
A non-opioid replacement that doesn't work through opioid mechanisms.
I think that's the most important thing. I'm convinced opioids, and I'm not a physician, I'm expert in having pain, but I think that I think the opioid's the problem, and I think the addiction's the problem. If we can find a way to cure addiction or at least reduce dependence and addiction, we'll be a whole lot better off. And I think that's what you said.
If I could just make a comment, I think so much of the legislation and a lot of has been concentrated on treating current addiction, which is obviously incredibly important. We have a country full of people who have substance use disorders. But I think that what you touched on is really important, the prevention of future addiction, preventing contact with pain medications that teenagers are finding in their parents' medicine cabinet or that they're coming in contact with when they have their wisdom teeth removed in high school. And I think that's really going to be essential for future generations.
Well, I appreciate it. I think so too. And having 3 children and having 9 grandchildren, I see what we get in our medicine cabinet at home for them. And it's important that be managed as well as possible to keep kids from getting something and getting addicted to it without us even knowing it. And my grandson, who I lost, he's a step grandson, was not with me all his life, but with me a lot of his life. He was addicted before we knew before anybody in the family knew what he was getting or where he was getting it. But it was a medicine cabinet that got him started, and peer pressure that kept him on it, and dependence that caused the problem. So I appreciate what you said, what all of you said. I appreciate what you're working on, and God bless all of you for doing it.
Well, I'm terribly sorry for your loss, sir. We do know that 80% of people who eventually develop heroin use disorders and other substance use disorders start with a legitimate prescription that someone received, not necessarily themselves. Sorry.
And Senator Isaacson, I totally support your emphasis on research. As I mentioned, the HEAL initiative is a great start, but we've underinvested in research for the number one reason why people go to the doctor. Less than 2% of NIH's budget was dedicated towards pain. We still don't understand the basic mechanism of pain in the body. So we really need an investment in research commensurate with the burden of pain. And I think we're going in the right direction, but we have to keep going there.
Thank you, Mr. Chairman.
Thank you, Senator Isaacson. Senator Murray.
Yes, thank you very much to all the panel. Really appreciate it. Throughout this committee's bipartisan work on the opioid misuse crisis, I have heard from people who supported our legislative efforts, and we're very grateful. But I also heard from some people with disabilities who experienced pain and feared that restricting access to treatment could affect independent living merely because they were unable to manage their pain. So, Dr. Gazelka, maybe you can take this on. Have we struck the right balance in our work to reduce misuse, but also making sure that treatments are available, which can be really vital for people with disabilities?
It's a very good question. And I worry that we've gotten ahead of ourselves with wanting to restrict opioids. A lot of providers are now scared to provide opioids to patients they've been prescribing them to for many years. But that doesn't necessarily mean that those patients have come in contact with a pain provider who can help them manage their pain, but with other means. Most opioids in the United States that are prescribed chronically are prescribed by primary care providers, many of them who don't have any education in managing chronic pain. They don't have time to go into the detail that it takes to talk to patients about other options. They don't have access to pain providers. And I think in some ways, we've done what needed to be done, which is to drastically reduce opioid prescribing, I think. But I worry that we're getting ahead of ourselves with having available other options.
Okay, thank you. I know people experience pain in a lot of different ways, but one other thing I'm really concerned about is how bias in the healthcare system can affect a patient's treatment for pain. Despite the fact that women experience pain at higher rates than men, they are more likely than men to receive sedatives or be diagnosed with a mental health condition when they seek treatment for pain. And when it comes to cardiac care, women are less likely to have their heart attack symptoms recognized or to receive painkillers after a cardiac surgery. And it's just, when patients aren't listened to, the results can be debilitating, even fatal. So Dr. Gazelka, maybe I can ask you, have you seen female patients being treated differently than male patients?
I have a patient who has not only given me permission to share her story, but has encouraged me to do so. 60-year-old lady in 2017 went to her local provider in a small town in Minnesota with abdominal pain. She'd been very active running before this. As the year progressed, she became less functional. Her primary care provider did not know what else to do for her other than ordering a CT scan of her abdomen and ruling out any difficulty there. She started presenting to the emergency room locally. After multiple presentations, the emergency room physician sat her down and said, "Mrs. B, you have chronic pain. You're going to need to go home and figure out how to manage this." She was frustrated, so came 2 hours to the Mayo Clinic emergency room and eventually ended up on my schedule in the pain clinic. Now, talking about bias, I admit that when I saw that on the schedule and I read her history, I just felt a little irritated that morning having to go into the room. But I stood outside of her room and I told myself, you're going to listen to her like this is the first time she's told her story. And I went in and I listened to her. And I ordered an MRI that showed that she had a metastatic lung cancer eating through her rib and the nerve that innervated that area in her abdomen. It had been present for at least a year and ignored because people felt that she was seeking opioids. Bias is a significant problem in all areas of medicine. It's a problem in research. It's a problem when we see patients. And it contributes significantly, I think, to the stigma that surrounds the treatment, not only of chronic pain, but of addiction and of mental health disorders. I think it's a significant issue.
I'm not sure how we address that, but being aware of it is certainly a critical part of it.
I think awareness and I think education, both for patients and providers,
Yeah.
the public as well.
And I understand people of color, same.
Yes,
biases.
there are definitely studies that show that, yes.
Ms. Steinberg, I wanted to ask you, can you share your experience in providing a healthcare provider who helped you manage your pain, and your thoughts on how Congress can help make sure that providers have the tools they need to support patients who live with pain?
Yeah, I think it's a great question because I've often asked myself after 5 years, why did it take me so long to find somebody? And what was special about this doctor that finally helped me? And it wasn't anything miraculous. And that's, I think, an important message today, which is he empathized with me. He believed me. A lot of people with pain don't get believed because it's an invisible disability. He said, I will work with you to help you find things to manage your pain, but understand that there is no cure now for chronic pain. You probably have chronic pain and you're going to need to learn to live with this, but I will partner with you. He was honest. He was empathetic, as I said, and he worked with me to find things that help me. We often say in pain management now, if you do a program of several different things, and what I do is I take medication, I limit the amount of time I'm up. Everybody has different limitations on their activities with pain. I do a water-based therapy, physical therapy program, and a land-based program. So if each thing takes down your pain 15 or 20%, it adds up to maybe a 50 or 60% reduction in pain. You can live that way. But it's a matter of having doctors have the time to do the coordinated care. Our system is so fragmented now that people go from doctor to doctor. Nothing is coordinated. They try one thing, it doesn't work. They go to another person because they're desperate. But if we had coordinated care, think about cardiac rehab. Heart disease has been a huge cost for us, right? But we focused on cardiac rehab and said, we are going to have a rehab program that puts everything together. And we've had great success with that. Pain needs something like that. We need that kind of approach where there's an integrated care center. Doctors have time to provide that care, and you can try different things and have somebody helping you. You're not isolated. It would go a long way to saving a lot of the wasted costs from trying different procedures and different needles and different injections. And this is what happens to people with pain. So that's my suggestion. It is not miraculous. I think we can do this if we rethink and realign insurance reimbursement and think about models of care that are creative that way.
Thank you.
Thank you, Senator Murray. I'm going to try to keep the questions and answers to 5 minutes each since we have, but let me go back to you, recognizing I've only got 5 minutes, Ms. Steinberg. We have 300,000 primary care doctors in the country. They're the access point for most of us to whatever else we need. How do we empower them to do a better job as you just described?
So that is a great question because I've been working in policy in Massachusetts for at least 11 years now. And I've worked with lawmakers to try some innovative things. And we just passed a law, something that I worked on, which was patients are being dropped from care right now. Excuse me, you've heard the doctors are afraid to take care of people with pain. And the bulk of people with pain end up, because we have so many millions, being taken care of by primary care physicians who don't get much training in it. So we
I don't
try.
want to cut you off, but I've got several questions.
Okay, so we tried a program where primary care doctors can call pain management specialists for consultation free of charge to them. So the state is going to pay for specially trained teams of pain management specialists who can consult with the doctor so the doctor feels more comfortable handling that patient. They have a network of alternative providers, and that really is helpful.
Dr. Gazelka, does the Mayo Clinic have such a system to connect with primary care doctors around Minnesota or other states?
We do have a system within our electronic medical record. We allow for e-consults where the physician or provider can contact a specialty physician and ask for advice to treat that patient and ask if a referral might be appropriate.
Dr. Koop, this hearing for an obvious reason, it's called human nature. You set out one direction and it's the right direction, but you know for sure that something's going to happen that could cause in the other direction you didn't anticipate. And that's what we're worrying about here today. Let's say I have a loved one who's about to have a serious surgery. How do I think about opioid prescriptions in a state like Tennessee, where the state has said, with our encouragement, 3 days per prescription? How should we think about opioids? Is this something you don't use at all? I noticed that Blue Cross in Tennessee won't reimburse Oxycontin, although I don't think that may be true for other opioids. But how should one think about that? Looking at it from the point of view of your own family and someone headed toward a painful surgery.
My own family takes opioids, and I'm fully supportive of them taking them. If somebody needs opioids, they should get them. I really don't think one of the issues is the pendulum has swung way too back to limiting and people suffering from pain. We need to get to the middle ground where opioids are used in limited quantities, but we also add all the other approaches that we've had.
What is a limited quantity? 3 days or 3 weeks?
I'm not a physician. I can't answer that. I'm sorry.
Dr. Gazelka, what's a limited quantity?
That varies by the patient and the procedure.
Well, what would a range be?
Between, I think 3 days is very reasonable for emergency room presentations. That's what we've instituted at Mayo and actually throughout the state of Minnesota with other healthcare organizations cooperating. But I think for a knee surgery, we know from research that it's about 16 days of opioid that a patient takes. Mm-hmm. What is appropriate is to educate the patient and perhaps with the participation of a pharmacist, educate the patient that you should take this for the shortest amount of time possible. The risk for maintaining long-term opioid use increases dramatically at about 10 days of use.
Dr. Koop, I have about a minute left. What are the most promising non-addictive painkiller treatments or medicines coming down the road? And you can mention your own.
My own would not be approved. My own would not be approved. It does indeed cause less dependence and tolerance, but it is reinforcing. So that's why I say the FDA needs to fully address all these drugs. My drug should not be approved. It would be the worst thing to put onto the market. I'm working on the next generation. The drugs that are coming, I mentioned cannabinoids. I really do. And I know that's a controversial topic, but there is great...
Why is it controversial?
Certain states have legalized. The federal government has not legalized. The studies out there, have potential, but the studies have been done with no systematic approach. We need systematic approach.
You're talking about medical marijuana?
Yeah, medical marijuana. Sorry. Yes, medical marijuana.
We're laymen, most of us, women.
Sorry. I'm really sorry. Medical marijuana, yes. I think that has great potential.
Thank you very much. Senator Baldwin.
Thank you, Mr. Chairman. As our witnesses have all noted, pain is a complex issue. It's especially true for patients who are struggling with serious conditions such as cancer, who often need palliative care services to manage painful symptoms from treatment. My home state of Wisconsin has embraced palliative care as a critical component that focuses on patients' needs, explains the treatment options, and gives patients and their families a real voice in their care. Many who need palliative services can ultimately recover and continue to live meaningful lives. I've had the honor of working with my colleague, Senator Capito, on bipartisan legislation, the Palliative Care and Hospice Education Act, which would help grow and sustain the palliative and hospice workforce to help fill the needs and wishes of patients and their families. Our bipartisan bill passed the House last session with unanimous support, and I look forward to continuing to work with my colleagues on this committee to advance this measure through committee this year. Dr. Gazelka, you stated that Mayo Clinic's clinical guidelines were developed after extensive research on prescribing practices among providers, but also with feedback from patients. I wonder if you could discuss how the Mayo Clinic continues to refine these guidelines for patients with palliative care needs, and what else is really needed to improve the training that palliative care professionals get to provide the best care possible.
Well, that's a topic that's near and dear to my heart. I left my practice to go back and do a palliative fellowship at the Mayo Clinic several years ago. I think that palliative care is essential. I think what you said is key, that not all patients who receive palliative care, they're not dying. They're people who have serious medical illnesses, chronic medical illnesses, and often studies show that they perform better if they receive those types of services. We have a robust palliative care service at Mayo. We're training fellows each year, but it's a new specialty, and there's a paucity of providers, way too few, and so training is really important. Most guidelines, including the CDC guidelines and other state laws that have been passed, for instance, have exemptions and exclude cancer patients and patients receiving palliative care. At Mayo, we started out in the same vein, but recognizing that with the treatments for cancer and with the palliative care measures that we are able to provide to patients, that these patients are surviving. They're being cured of their cancer, or their cancer is becoming a chronic disease rather than a terminal illness. And so their risk of addiction is high. It's as high as any other patient who takes an opioid medication. And so we have focused efforts on instituting essentially the same guidelines within our palliative care clinic as we have elsewhere in our clinics. Appropriate opioid use, because there are many, opioids, we call it a stewardship program for a reason. They're vital, important. They're the best painkillers around. They've been around for thousands of years and probably will continue. Very important. But we need to be good stewards of them and teach our patients to be good stewards as well. I hope I answered your question.
The dangerous misuse of opioids at a VA facility in Tomah, Wisconsin, a few years back resulted in the tragic death of a Marine veteran named Jason Simkoski. His story inspired me to author the Jason Simkoski Memorial and Promise Act, again with my colleague Senator Capito, which has been since signed into law. But the law reforms the pain management and safe opioid prescribing practices in the VA system, including by creating pain teams that are that incorporate provider education and expand access to complementary and integrative health services. Dr. Koop, you noted that the safe use of opioids requires a multifaceted, team-based approach to pain care that includes patient and provider education. Can you discuss what your research has shown to be necessary for such comprehensive care to truly address chronic pain, and describe the important role that pharmacists play as a part of those teams?
The research behind this is that those teams do not always work together. We need to ensure that those teams do work together. There are perverse financial incentives not to work together. So one of the things that we need to do is to ensure that the financial incentives are there to ensure that the team works together, so that we educate people and put the money at the front end, so we're not putting the money at the back end.
Thank you.
Thank you, Senator Baldwin. Senator Collins.
Thank you, Mr. Chairman. Dr. Gazelka, last year, the Aging Committee held a hearing on opioids and seniors. I think many of us, when we think of the face of the opioid addiction, automatically think of a young person, usually a young male person. However, what our hearing showed is that this epidemic also affects our older adults. And if you think about it, it's not surprising, since nearly half of older Americans do suffer from chronic pain, and the incidence of chronic pain increases with age. The Centers for Disease Control estimates that the number of people aged 55 or older treated in emergency rooms for opioid overdoses increased by nearly a third from 2016 to 2017. Now, some research suggests, however, that opioids are really not effective in treating chronic long-term pain, except in cancer patients. First, I want to ask if you agree with that finding.
For the most part, yes. However, I have found in my own practice and with other pain providers, it's commonly we do use opioids for patients who don't have other options. And many times as patients are aging, they may not have some of the options, such as surgical interventions, procedural interventions, implants, et cetera, that might be available to a younger patient simply because of their medical comorbidities.
Ms. Steinberg.
Yeah, I do want to address your question because I talked about the doctor that helped me. And when I went to him, I didn't want to take any medication because I'd heard horrible things about pain medication. And he tried me on a lot of other things first, like gabapentin, which is common. It made me so tired I couldn't function. But he convinced me to try hydrocodone Tylenol combination medication. And I tried that medicine and it helped me. And I never got high from that medicine. I took a relatively low dose of it, but I took that same medicine. It allowed me to function. I still had pain, but it allowed me to function and become the advocate that I could. I took that medicine for 10 years at the same dose. I never had to change my dose. I never got a high. And most people with pain have that experience. Unfortunately, people with substance use disorder, it's a genetic disease. You often start with tobacco or alcohol or other things. And I want to draw a distinction. I think the misunderstanding is people think every time you take an opioid, you get addicted. I want to draw a distinction between two largely separate populations. People with pain tend to be women over the age of 40. People with substance use disorder tend to be men under the age of 30. We're talking largely about two separate populations, and Nora Vocal herself wrote a prominent article that said that people living with chronic pain, people with pain who take the medication for pain, less than 8% of those become addicted. That means 92% don't. So unfortunately, it's clearly some people do become addicted. I think that you need to make a distinction and understand that for some people, they are helpful and they're the right thing.
Right, and I'm not implying that they are not, but there is research that says that for long-term use for chronic pain, for many people, that there are better alternatives to opioids. And that's just the point I was wanting to explore. Dr. Coop, very quickly, because my time is almost done, a substance abuse expert has told me that an individual who is given opioids, who is under age 20, is far more likely to become addicted than someone who is older because of the brain not being fully developed. Is that accurate?
That has been widely studied, yes. And if you, for instance, look at when people start experimenting with any drug, it tends to be at that age group. The brain is still developing until your early 20s. So that is why, yes.
It's interesting because you think of young people having their wisdom teeth taken out and being given opioids. And I know that many of the dentists in Maine have switched to strong doses of ibuprofen followed by Tylenol and alternating it every 2 hours, and have found that the pain relief is just as effective and safer. And I see two of you nodding your
Yes,
heads.
yes.
I think acute pain, particularly in acute pain, is where we've had to cut back and should cut back with opioids. And for dental procedures, it's usually unnecessary. And hopefully they've gotten the message now.
Thank you.
Thank you, Senator Collins. Senator Hassan.
Well, thank you, Mr. Chairman, and thank you, Ranking Member Murray, as well, for holding this hearing. Thank you to all of the witnesses for being here. We really appreciate not only your presence, but your expertise and your commitment. As you know, New Hampshire has been especially hard hit by the opioid epidemic. And we also have many patients who are suffering from chronic pain. So we need to make sure that all of our patients have what they need to access care, including those suffering from pain, as well as people who are suffering from addiction and mental health conditions. But provider shortages in all of those areas is a real issue in my state. For example, Dartmouth-Hitchcock, which is the largest healthcare provider in New Hampshire, has between 750 and 800 open positions at any time. And the state's community mental health centers have more than 175 vacancies for clinical positions. So this first question is to Dr. Koop and Dr. Gazelka. As faculty of pharmacy and medical schools, I'm interested in what you see as the greatest workforce challenges and your views on the role graduate medical education plays in training the next generation of physicians. And the follow-up to that, you can answer both. How could additional residency slots, particularly in fields like pain management, addiction medicine, and addiction psychiatry, improve access to care for patients? So Dr. Gazelka, if you'd like to start, and then Dr. Koop.
I think it's probably not a popular thing to talk about, but I think the cost of medical school and the loans that students accumulate during the time that they're in their medical training are cost prohibitive in some cases into going into some of the primary care practices and some of the lesser reimbursed practices, which may be such as, primary care, psychiatry, addiction medicine, et cetera. And I think that's a real problem. I remember at the time that I was in medical school at the University of Minnesota, the dean came and spoke to our class and said, so many of you are planning to go into specialties, you need to go into primary care. We need primary care physicians in Minnesota. But at the same time, the University of Minnesota Medical School was the most expensive state medical school in the United States at that time. And those considerations have to be taken. And so I think finding some way to encourage students to go into specialties that are needed would be important in that regard.
Thank you. Dr. Koop?
Approaching this specifically from pharmacy, pharmacists, as I mentioned, are often the most underutilized of healthcare professionals. They are the medication experts.
Yeah.
They are. I teach them all about drugs. They're also taught how to counsel patients, how to appropriately counsel patients with medications. One of the biggest issues we have with patients taking medications is actually taking the medications.
Right.
Right? If the medication doesn't get to the patient, it's not going to do any good. So again, part of the financial model, though, is reimbursement for those cognitive services. And it's getting those reimbursement for those cognitive services could bring the pharmacist into that healthcare team, which would expand that access you're talking about.
Well, thank you. And that brings me really to my next question, which was about reimbursement. And again, to Dr. Gazelka, we know it can be a powerful tool to influence the availability of services as well as providers' behavior. And that the lack of appropriate reimbursement, to Dr. Koop's point, it can create tremendous barriers for patients who need access to a variety of services. Insufficient reimbursement policies in federal programs like Medicaid and Medicare, as well as in private insurance, can sometimes create barriers to access to therapies and services that can reduce opioid use, including chiropractic services, some surgical interventions, acupuncture, behavioral health programs, and multimodal pain strategies. We've taken in Congress some important steps over the last few years, both in CARA and the support Act to help address some of these barriers. And certainly Dr. Rao Patel talked about things that Blue Cross Blue Shield is doing to try to eliminate some of those barriers. But Dr. Gazelka, can you give me some specific concrete actions that Congress can take related to reimbursement in order to improve patient access to non-opioid pain management therapies and services?
I am an interventional pain physician, and so I do neuromodulation. I implant intrathecal drug delivery systems, spinal cord stimulators, et cetera. In many cases, it is very difficult to get those covered. I find that Medicare is one of the most difficult when I have a patient on Medicare to have access to those therapies. Those therapies are proven in Europe to be extremely useful for chronic angina, for instance, so that patients don't have to pursue further stent placement, et cetera, or use opioids for chronic headaches, but the coverage for them is poor. I also think that I have rarely met a pain patient who wouldn't benefit from behavioral and psychosocial management. It's vital that we treat those areas for patients, and they're not covered. In the hospital, we'd like to allow patients who are having surgery to have access to a non-opioid management. We did a survey recently at the Mayo Clinic showing that 94% of patients would choose something other than opioids acutely after surgery if they could. But we can't provide acupuncture, we can't provide massage, we can't provide extensive physical therapy at sometimes and restorative therapies for those patients.
Thank you, and thank you, Mr. Chair, for your indulgence.
Thank you, Senator Hassan. Professor Cassidy.
Thank you. First, Ms. Steinberg, you're sitting back there, but I remember, and this will set up my next question. I remember having, when I was first year in Congress, having a slip disc in my neck with a radiating pain down my ulnar distribution, and it was so incredibly painful. I was imprisoned by the pain, and all day long, I just waited for my every 6-hour dose of Motrin and I staggered it with my Tylenol, taking something just when I went to bed. And for 3 or 4 months, that's all I did. And it just sapped my emotional energy. Now, I was eventually helped by epidural injections. And this sets up my next question, Dr. Gazelka. When I looked at the research on epidural, and for people who are not medicine, they put a needle right there, they injected it, and it would give me instant relief that would then wear away. I looked up the data, it said it was no good. The data says, epidural has no long-term benefit in the management of chronic pain. But after my third one, it just went away and never came back. Now, then I looked up the CDC guidelines for management of chronic pain, and they say, going back to Senator Collins' question, that there's really just no evidence of use of opioids long-term versus no opioids versus et cetera, et cetera, et cetera. So it seems like we have a paucity of evidence, and that which empirically worked in me, N is equal to 1, doesn't have the evidence to support it. Now, briefly comment on that, because then I'm going to go to my former student, Dr. Rao Patel, to ask if Blue Cross is covering things which have no evidence, but nonetheless empirically do work in some. So, quickly.
Well, so Dr. Cassidy, I do not have to explain to you that you can find studies almost to back up whatever you're looking to back up. You had acute pain. Epidurals very effectively manage acute pain, radicular pain. Probably for patients who have spinal stenosis or other types of chronic radicular pain, they may not be as effective. I could tell you that anecdotally from my practice. Do we use them? Yes, because they are helpful to them. Sometimes patients don't have other options available. But definitely for acute pain, those are helpful.
Now, of course, mine lasted 3 months. Now, eventually what my neurosurgeon friend told me is that just part of your nerve will die. Although I still have a little bit of something, I had tingles right there. And then after that death, that's a great way to look at it, I would feel better. So, by the way, I also once read in Mad Magazine as a kid, give me statistics and I can prove that Rhode Island is bigger than Texas. So,
that's right.
To your point. But Dr. Rao Patel, will Blue Cross pay for that which evidence suggests does not work? Number one. Number two, Dr. Gazelka mentioned all these wonderful things that can be used in lieu of opioids in the, say, post-surgical setting. But then my physician friends tell me, hey, you're on a bundled payment or you're on capitated payment, and the insurance company won't give you that bump up for the more expensive drug or the more expensive procedure. And I see Dr. Gazelka over there vigorously nodding her head yes. So tell us, since ultimately it comes to your decision as the UR manager for Blue Cross, how does that handle?
So along with her comment, there are studies that show that for acute pain, injections like epidural steroid injections work. Again, there are multiple kinds of injections for spinal pain, depending on where the pain generator is. And those are things that Blue Cross Blue Shield does cover. Several of the things that we've discussed, like physical therapy, occupational therapy, water therapy, chiropractic care, epidural steroid injections, facet injections, those are all a multitude of things that we cover as a plan without any type of prior authorization. So if a provider feels that this is the appropriate intervention for the pain, for the patient, for their pain, they can go ahead and do the procedure. They don't even have to contact us.
Now, let me ask though, because clearly given a prescription for opioids would be cheaper than a whole panoply of that, which might be less likely to induce. And it seems like that's the rub, right? If you're getting X number of dollars to manage patients, how do you employ that which is significantly more expensive, even though long-term there is a benefit?
Well, I mean, our approach at Blue Cross is, again, we've participated with multi-stakeholders at our state level, including the medical board and specialty societies on appropriate management and treatment of pain. And our approach has always been a multimodal approach.
So then let me ask, because I'm almost out of time, go back to the question of a bundled payment. And I don't know if Blue Cross uses bundled payment, but I can imagine someplace either you do or you plan to. And again, my pain management physicians say, listen, post-surgically, we can do this or that, but it's more expensive than just giving them a prescription or giving them an injection of an opioid. So how do we manage that? How do we approach as policymakers bundled payments when we know that it may increase the cost to do something which would decrease the use of opioids?
Again, the reason that we bundle payments, for example, is to be more cost efficient overall. So again, we're not trying to limit the options that providers have in managing pain, but we're encouraging them to use a multimodal approach in terms of management.
But I'm not sure that answers my question. Because if your cost basis is just giving a prescription for opioids, but the alternative is this, and he's lightly tapping his thing to tell me to shut up. So that'll be a question for the record. Thank you.
Well, maybe you could provide some, though Senator Murray'd like to know the answer. So we'll give, we'll extend the discussion for Senator Cassidy and ask you if you have any comment on what he just said.
Yeah, again, like I said, the things that, for example, that I'm aware of that we bundle at Blue Cross in terms of payment are, for example, post-surgery, let's say a patient has a knee replacement or a hip replacement. The perioperative period, the preoperative period, the perioperative period, and the postoperative period is bundled in a payment in terms of management of that patient. It's more of a payment question that I could get back to you on, and specifically what we bundle in terms of interventional pain management procedures. But there are instances where we do bundle payments in order to contain the cost.
Thank you, Dr. Cassidy. I think she said she wants to submit some homework to you. It's terrific to have a United States Senator who has a former resident student as a witness.
Yeah, I feel like I'm in his clinic right now. So.
Senator Smith.
Thank you, Chair Alexander and Ranking Member Murray. And I feel a little intimidated following Senator Cassidy because my knowledge of physiology is dramatically less than yours. But I really appreciate this hearing so much. And Ms. Steinberg, yes. Steinberg, pardon me. I think it's so important that you're here because in this committee, we all have our personal stories and we focus in on the policy issues, but and some of us have our own experiences with, pain in our families, but to be able to have you bring it down to reality is extremely helpful. So thanks so very much. Dr. Gazelka, I know that when I meet with healthcare professionals and families all across Minnesota, what I hear over and over and over again is the need for a coordinated approach to health problems that are complicated and can't just be resolved in one way, with one provider. And this is especially when you think about all the related issues that relate to whatever that one primary diagnosis is. And this is particularly true for pain management. And we know that chronic pain is associated with all sorts of issues like frustration and stress and depression, isolation. And I know that Mayo Clinic understands this so well. Mayo is renowned for the collaborative approach that you bring to all different kinds of health challenges, not only this challenge, but this seems to be particularly appropriate. So I'm wondering if you could just talk a little bit about the connection between pain management and mental health disorders and the tools that you see. I'm interested in getting from you kind of what we ought to be doing at the federal government level to encourage that kind of coordinated approach when it comes to pain management and mental health disorders.
It is well known, it's well understood that anxiety, depression, and other mental health disorders are far more prevalent in patients who suffer from chronic pain. They're highly prevalent. And so in treating the whole patient with pain, you must treat their anxiety, their depression, or other mental health disorders. I think an excellent example is the Pain Rehabilitation Center at Mayo. It's an integrative approach. It's housed within our psychiatry department, but it involves pain physicians, physical and occupational therapy, and it's a multi-specialty. I think we have gotten away from the pain clinics of 30 years ago, where patients would come in and they'd essentially see a team. They'd see a team that included a physician, that included a psychologist typically, that included perhaps a physical therapist or someone involved in restorative therapies. And reimbursement for that type of model declined. It became more interesting to do interventional procedures for patients, which are sort of a rapid, fix me now. And I think that a return to that sort of a model of chronic pain management is essential for caring for patients well. And so I think integrating those services is very important. And then addiction medicine, I can't tell you on our, we do so many surgeries a year. I couldn't tell you the number, but a lot of patients come in on chronic pain medications and they have issues with addiction. They come in on their buprenorphine, their methadone. Well, how are we going to treat their pain acutely? Well, they're hospitalized. Well, that takes some coordination with our addiction medicine colleagues as well. Because just because you have addiction doesn't mean you're not going to need a surgery or need chronic pain management at some point in your life. Our palliative medicine clinic is full of patients who have developed cancer or some other chronic or terminal disease even, but they also suffer from substance use disorder. And so we've had to coordinate care for those patients so that they can have appropriate management for their pain, but also for their substance use disorder or mental health issues.
So if we think about what we can do at the federal level to encourage that kind of approach, I guess this gets somewhat to the line of questions that Senator Hassan was asking about how our reimbursements don't support a comprehensive approach. Is that fair to say? The way we do and the way reimbursements happen don't support a comprehensive approach. Would you say that's true?
I think that is true. It's very hard. We for one thing, have a paucity of addiction medicine physicians and providers throughout the United States. But even at the Mayo Clinic, we don't have addiction medicine services in our hospital. Patients have to see those providers as an outpatient. Reimbursement is poor for that. And at a point where they could be touched and significantly altered in their course, they are not able to have that type of contact.
That leads to so much fragmentation and also in their care, which is bad. Bad recovery.
Even talking about buprenorphine coverage, for instance, there's so much talk about pharmacists providing buprenorphine, mid-level NPs, PAs providing buprenorphine, but you can't just give a patient buprenorphine. Buprenorphine can also be a drug of abuse. You have to give a patient the other addiction management services that they require to be successful.
Thank you very much. I know I'm out of time, but I appreciate that very much. Thank you.
Thank you, Senator Smith. Senator Romney.
Thank you, Mr. Chairman and Ranking Member. I appreciate very much the comments of the panelists, particularly Ms. Steinberg, who has made a real sacrifice in being here. Appreciate your coming here despite that pain. Your testimony, Ms. Steinberg, reminds me of my experience having served as the governor of the state where you now live, and I once did. And that is, we noted that we were spending a lot of money in Medicaid on psychotropic drugs, and we couldn't quite figure out why. And it determined that most of these drugs are being prescribed by primary care physicians who had very little experience in really deciding what the most effective psychotropic drug might be. And after some consultation, we said, Medicaid is going to no longer reimburse psychotropic drugs to young kids unless the doctor prescribing it contacts a physician at the University of Massachusetts Medical School that is a psychiatrist or in that trained field. That doesn't mean that the psychiatrist had to approve the prescription, just they had to have a conversation. And by doing so, we found that the number of prescriptions dramatically came down and the quality of care, we believed, substantially improved. I think each of you has spoken about the fact that most of this prescription of opioids is being done by people who are not specialists in the field. And I wonder whether the lack of best practices is not something which is really affecting the challenges that we're facing, both for those that have chronic pain and for those that are abusing these products. Should we have some mechanism that one gathers data from all over the country, from everybody who's using these drugs to see what the effect is, but number two, a place where physicians go to get a consult, if you will, before they prescribe for someone that has chronic pain, prescribe medication for someone with chronic pain. Do we not need something of that nature? And how would something like that be structured at a state or national level? And I'm happy to turn to any one of you that'd like to comment on that.
The program that I mentioned is one attempt to do that. We're doing that in a small model where PCPs can call for consultation. I think that's a great idea. One thing that's not a good idea, I think, that was tried, I think it was in Washington State, said that nobody could get an opioid prescription without having seen a specialist. And it turned out there's like a handful of specialists in the state. And so people with pain who really did need their prescriptions could not get their medication. They had to go out of state to get their medication. It was a disaster. So I really encourage us to think through the way we implement that. Clearly, education is the other side of what you're talking about. And there is an absolute dearth of pain education. We're not training people on what we now know.
Well,
So medical schools just absolutely are ignoring this.
The challenge with that is that if you take more time on one subject, that means less time on another subject. And so consult may be a way we need to go. I'm going to ask with regards to Blue Cross Blue Shield, are you able to get expertise to the people who are making these prescriptions?
So to answer your question, I'll say one thing is that oftentimes it needs to be the primary care physician who's managing the pain. Because, for example, in North Carolina, with a lot of rural areas, access to a primary care physician can be challenging, and access to a pain management doctor can be even more challenging. So we have really we actually just started working with a new company, Quartet, who's bringing behavioral health and mental health into primary care areas to empower primary care physicians. There's also something that you might have heard before, Project Echo, which is a platform that several Blue Cross plans are already using, which, if anything, is sort of a grand rounds, if you will, where primary care physicians or any type of physician can call in and seek expertise from people who are addiction specialists or pain management doctors. And it's meant not only for a consultative purpose, but also an educational purpose. So that way the physician learns in the future how to manage a patient that way.
Thank you. Please.
On that, Senator Romney.
Yes.
We have on a small scale at Mayo begun we need to leverage telemedicine and electronic medical records, which are now more and more beginning to speak to each other. Finally, at Mayo, we have an electronic health record that speaks to, so we can talk anywhere in the country about our patients and look them up. We have developed a controlled substance advisory group where specialists such as myself sit and hear the cases that are brought by primary care physicians, that they bring forth, patients with difficult pain management problems, patients with substance use disorder problems, et cetera. And we have specialists from all those realms who sit at the table, provide advice, and then we enter a note in the patient's medical record stating what the decision of the panel is. And I think I have visions of expanding that because I think it would be incredibly helpful to primary care providers. Obviously, there are HIPAA, restrictions and things like that across various states, but I think it'd be a great.
Thank you. My time is up, but I do want Dr. Koop to instruct us as to the path forward on cannabis research, but we'll save that for another day.
Thank you, Senator Romney. And of course, if any of you have additional comments that you'd like to make to senators, you could submit those in writing after you leave. Senator Rosen.
Thank you, Senator Alexander, Senator Murray, and I really appreciate the panelists here. I hope that my acute pain from wrist surgery does not turn into chronic pain, but that's another issue. But what I want to say is before coming to Congress, I stepped back from my career for several years, was a caregiver to my parents and my in-laws. During this time, I became very familiar with the field of medicine known as palliative care and the relief from pain symptoms, of course, and the stress that the specialized care can provide. Palliative care focuses on improving quality of life for those with often life-limiting illnesses, including those in significant pain or having terminal illness, often in that gap between end of cure and end of life, like my mother. Last Congress, I launched a bipartisan palliative care task force in the House to bring attention to this type of care. I'm hoping to do that here. So I have a couple of questions for you, Dr. Gazelka. In your experience, is it common for patients diagnosed with chronic pain or possibly terminal diagnosis to have those conversations with their doctors about palliative care as a treatment option? And how can we ensure, specifically with primary care physicians, that they understand the needs of terminal or long chronic pain patients? How do we do that? Possibly maybe requiring ongoing CME for primary care physicians in this area.
I think that's a vitally important topic and not common enough. I think patients make choices that they don't want to make to come in and have treatment for things that they would not necessarily choose to have treated. 100-year-olds ending up in the ICU with pneumonia or with a hip fracture because no one had a conversation with them that it's okay to be comfortable and to even do this at home, perhaps on hospice, to be taken care of, or in another nursing facility. And so I think empowering patients to have those conversations with their physicians is vitally important, and training physicians and other providers to have those conversations is
Do you think
really
that we
key.
could possibly provide that by improving the way we use continuing medical education, maybe requiring this pain management, chronic pain management as an ongoing CME requirement, especially for primary care physicians? Do you think this is something that we could help?
I think it would be helpful. We have instituted in our medical school, for instance, a palliative care education program, very uncommon in medical schools, but people need to have not only an understanding of what patients' rights and preferences might be, but know how to have conversations. And it's the skills of having critical conversations that are vitally important.
But do you think to retain board certification possibly in family practice or a primary care physician requiring, just like we do for mammograms, certain requirements or hours, this could be a way we could go?
I do. It's being required for opioid right now too. Yeah.
I have a question also for Dr. Koop about medical marijuana. In Nevada, we've ranked 13th in the nation in prescribing opioid painkillers. Our former governor took action by forming a new state agency, the Opioid State Action Accountability Agency. We do have legalized medical marijuana in Nevada. We have found that using that has reduced the prescriptions for high-potency painkillers. And so, in your experience, what do you think are the barriers into effective research for the benefits of cannabis treatments? And how can this possibly be can this possibly be a non-addictive approach or alternative to chronic pain, just another tool in the toolbox?
I first of all think it has great potential to be another tool in the toolbox. I don't think there's ever going to be a one-size-fits-all magic bullet because pain is different in different people. In terms of how to move the research forward in medical marijuana, one of the issues has been because of the unusual legal status, shall we say, in the United States, research has been limited. There's no consistency between the different types of marijuana, the studies done. So what we need is good. They're going on, some are coming, but we need more. We need good, consistent, well-designed clinical studies with good, consistent material so that we can fully assess the impact. Don't get me wrong, also the potential drawbacks.
Right, like everything else.
Yes, right.
Thank you so much.
Thank you, Senator Rosen. Senator Murkowski.
Thank you, Mr. Chairman and Ranking Member. Thank you for this conversation this morning. So important. And I really appreciated the back and forth there with Senator Romney. Clearly coming from a very, very rural state, when you're dealing with how you respond to patients' pain issues, and you don't have access to perhaps those alternate pain management technologies, the different therapies that are available, the quick and easiest and cheapest, to Senator Cassidy's point, is the prescription drug. And so this idea of e-consult is really critical. We pioneer a lot in the telehealth space, but making sure, again, that there will be reimbursement for these consults is important. And Dr. Rao Patel, the words that you used where you were empowering the primary care docs, but translate that to me. Do you cover these consults then?
Yes, we do. We do cover telehealth.
Okay.
And in fact, like I mentioned, one of the things that we're doing is
And telehealth specific to these types of pain management consults.
correct, and a lot of behavioral health telehealth as well as as it's used to treat opioid use disorder as well.
Good.
So I guess one of the things I was going to mention is, that's one of the things that we've really developed and are expanding on, at least in our Blue Cross North Carolina program, is increasing access for folks, especially in the rural areas that we talked about, to be able to access providers that they wouldn't otherwise be able to through telehealth.
Right. Let me just, I'm going to ask one question for all of you here, so you can probably jump in on this, Ms. Steinberg. The big conversation over the Christmas and the New Year's holiday back home was what we're seeing with constituents in our bigger population centers, so out of the rural areas, but in Anchorage and in Fairbanks, they're being denied prescriptions where the prescription drug is opioid-based. It's this. Some of it goes to the bias issue, but it's the pharmacists that are refusing to fill the prescription. The doctor has prescribed, and we're not certainly the involvement that we've had with these constituents, it certainly doesn't appear to be abuse situation, but people who have legitimately been prescribed these pain medications for these debilitating and long-term pain management issues. And I understand that it relates to the recent guidance coming out of CDC recommending restricting how much a pharmacy can do. The guidance isn't controlling law, but in an abundance of caution, the pharmacists are saying, no, we're not going to do this. So you now have the patient in the middle of a regulatory debate, if you will, and it has caused the lid to be blown off the discussions in my state, and I can't imagine it's just in Alaska. What are we doing to address this tension now, this conflict between prescriber and the pharmacist, and then ultimately we want to be helping the patient, but we've got a struggle going on, and I don't know who is addressing that. Can any one of you speak to that?
There is a terrible climate of fear out there among all practitioners right now. And they don't even want to treat people with pain anymore. That's how it's gotten that bad. And I had, just like your example, I had a doctor from Dana-Farber Cancer Center call me saying pharmacists won't fill my prescription for patients that I have they're really bad cancer. And so it's gotten to a point where it's just gotten so unreasonable. There's a hysteria out there.
So what do we do?
I think we need to educate everyone better about this issue. I think we need public education about pain and the fact that pain is a disease itself. So people understand that we're not just talking about acute pain here. Chronic pain is devastating. And for the kinds of things that you're talking about, Pharmacists are not getting proper training in that. I don't think anyone is getting enough training in pain.
So it's pharmacists who aren't getting the training, but you've also said that the physicians don't get enough.
Correct.
Dr. Coop?
I was just going to say that folks do view guidances as being like gospel. So I think those guidances on the quotas, I think they've been taken too far, and that needs to be rolled back. There's one thing that can be done. Yes, all healthcare professionals could certainly benefit from more education in this area.
The other thing I wanted to add to this whole discussion of specialists and consult and telehealth is that we don't have enough pain management specialists. And I know Senator Hassan has left here, but she brought that issue up. There's so few doctors specialize in pain management that it takes people more than a year in my pain group to get an appointment with a pain specialist. There's a dearth of them, and I don't know, in your state, I can just imagine how few there are. So we're talking about consults and telehealth. They're not even the specialists to handle the telehealth. We need to incentivize pain management as a specialty. There is a board certification in it, and there's a dearth of physicians.
I just wanted to comment on the unintended consequences of some of the use of the CDC guidelines. There's only number 6 in the CDC guidelines. It's a very small section talking about acute pain management, that 3 days, at the most 7 days, should be considered for acute pain management. It's been made into law in many states, and many insurers have used this. It's not a problem of pharmacies at the Mayo Clinic. It's a problem of our insurance companies. We literally are keeping patients in the hospital longer because we cannot get their prescription for discharge pre-authorized so that they can go home to North Dakota or they can go home to Montana. They are staying in the hospital because the physician will give out a prescription for 2 weeks of opioid, which is what we have decided on our, if that's a certain procedure that we've decided that on our guidelines. This has to go to their insurance company. Our pharmacy has to submit it. Patient can't get a prescription for that length, so they stay in the hospital while we work that out. There's been some significant unintended consequences in multiple of the pharmacies as well. Larger pharmaceutical companies, and I've spoken with some of them on the phone, have arbitrarily set 7-day limits on what they will allow patients to have, and they cancel the rest of the prescription from the physician. This means more trips back to the doctor for the patient who may have just had surgery. This means another copay for the patient who has already paid one copay for their opioid when they need a refill. So it can be a really significant issue. I respect that.
And the task force has looked at the CDC guidelines and have some really great recommendations on how they need to be revised. Picking a dosage level is an arbitrary decision. It was not scientific based, and it's now become law, and it's caused all kinds of problems.
Can I just add one thing to that? I'll just say that I think a lot of the issue with the CDC guidelines are just that. I think it's a lack of education on a part of the physician, as well as the pharmacist, in understanding that they are just that, guidelines, that they are going to be patients who will potentially look like outliers and go higher than what CDC recommendations are, and that might be entirely appropriate for that patient population. So I just wanted to mention that as well.
Thank you. Mr. Chairman, I know we're well over, but we've apparently revealed something here.
Well, we're all interested in those answers, and I think it's worth saying that we considered and rejected the idea of a federal law establishing 3 and 7-day prescription limits, leaving that to states and physicians and caregivers to work out. And I think that's proving to be a wise decision. Although I hear what you say about CDC, but Senator Jones from.
Senator would be fine.
That's all right. Senator Jones you have a doctorate from law school.
That's right. Thank you, Mr. Chairman and Ranking Member. Thank you all for being here today. One brief comment. I appreciate the comments about telehealth and telemedicine. We are continuing to have our rural hospitals and providers leave our rural area, and I've always thought that telemedicine and telehealth is one way to try to keep that. It is only, however, as good as our rural broadband and access to the internet, and that is something that my office are continuing to push for, and I would, any help on that area to try to get broadband in those areas would be great. I do want to follow up, though, with an area, and a lot of times when we ask these questions, people think we're going at it with an agenda, and sometimes we are and sometimes we're not. This is not one of those. But Senator Rosen asked about the research and development using medical marijuana and cannabis. And Dr. Coop, you gave a very good answer. I appreciate that very much. But I'd also like to hear from the other three of you on this issue. I do think it's an important topic. It is one that in the public's mind is growing throughout the country. And so with each of our physicians, as well as Ms. Steinberg there, if you would, we'll just start with you, Ms. Steinberg, if you could comment on the pros and the cons of what you see in the developing of medical marijuana, cannabis, the ability to use as an alternative, but also the research that would be required to go into it.
Yes, and actually cannabis has helped a number of people living with pain. I mean, it's another option, as we talk about in the toolbox. It has helped a significant number of people, but it's not legal in a lot of places. And therefore, even where it is legal, as Dr. Coop said, it is not standardized. Doctors need to be the ones prescribing it, but they don't know what they're doing with it. They're not trained with it either. And so without having a real good research base, we're just flying, blind.
What prohibits the research base?
The fact that it's not legal.
Okay, just wanted to get that in the record, that we're it's a scheduled substance, so that it limits the amount of research considerably that can go on into both the pros and the cons of this. Yes. Okay, thank you. Dr. Gazelle?
I don't think we do know that marijuana is not addictive. I've certainly seen patients who have excessively used marijuana, not medical marijuana perhaps, but pot. It is believed to be an addictive substance. And it is, not that many years ago, we heard that opioids weren't addictive. And so I think we have to proceed with caution as with anything else. I think the inconsistency among the products that are produced with the ratio of CBD to THC, et cetera, is an important component of this that will factor in when it's being researched. But I think the impediment has been that it's a Schedule II, a Schedule I substance, rather, and it's not permissibly prescribed by providers. But I do think that there may be some significant areas where this may be very useful. I have some palliative medicine patients using it for nausea, appetite, et cetera, and I think pain. I think it can be helpful.
Right. Yes, ma'am.
So I would agree with that. I think that there's, due to limitations such as the fact that it is illegal in some states as well as on a federal level, make research difficult. I think a lot of times I have seen patients of mine in the past who were taking opioids and, if we did a urine drug screen on them, they tested positive for marijuana and they found that seemed to help more than being prescribed an opioid or any type of adjunctive medicine to an opioid. So I do think that there potentially, from a physician standpoint, I think that there is some potential to the utility of medical marijuana for the management of chronic pain. I'll say, putting on my other hat as an insurer hat, that we obviously only cover procedures and drugs that are FDA approved. So we would obviously need some clinical evidence and support to be able to cover those kinds of medications.
Have any of you got any suggestions other than short of removing it off of Schedule I, which I guess you could do and put some other weird restrictions, I guess. What can we do is there anything other than that we can do to open up the ability to research the pros and the cons of medical use of cannabis? Or is that the impediment that we've got to try to figure out how to deal with? Dr. Coop, you?
I was going to punt this. I would say that this is a decision that the National Institute on Drug Abuse, that with the experts that could know all the confounding factors, it would be something that I think we should charge those guys with coming up with what is the best way forward.
Okay, great. Well, thank you all for your answers and thanks for being here. Thank you, Mr. Chairman.
Thank you, Senator Jones. Senator Murray, do you have additional comments?
I just would like to thank all of our panelists for being here today. This has been, I think, really an interesting and eye-opening and important hearing, and I want to thank all of you for your help today.
Well, I agree with Senator Murray's sentiments. I only have one question. Several of you have mentioned in response to questions from senators that what we could do about this is public education. Well, that's what we're attempting to do today. The United States Senate is a forum that helped lead the way to recognize opioid abuse and try to deal with it. And we should at the same time try to lead the way to determine whether there's some unintended consequences and whether the millions of Americans who live with pain are not able to deal with pain as a result of the reaction to the effort to stem opioid abuse. We've heard today that reimbursement policies are important, that primary care doctors and their education is important. We've talked about the most promising non-addictive pain medicine. That's been a priority of Senator Murray as in her role as a senior Democrat on the Appropriations Committee that deals with health, and this committee where we've attempted to push more funds into the National Institutes of Health toward non-addictive treatments and medicines. And Dr. Collins has been here to testify on that and is working in a variety of ways to accelerate that. We've talked today about pharmacists and what their role might be as we go along. But I wanted to ask one last question about the CDC, the Center for Disease Control recommendations. They're not law. They're not rules that anyone has to follow. But the CDC is enormously respected in states and in the medical profession. And in this environment, sounds to me like, Ms. Steinberg, that your experience of using a low dose of hydrocodone and one other over-the-counter medicine for 10 years to relieve pain wouldn't fit with the CDC guidelines for your doctors. So what recommendations, my final question would be, and you can elaborate if you'd like to after you leave, and you could submit it in writing, but each of you, what would be your recommendations about the existing guidelines of the Center for Disease Control, guidelines for opioid abuse, and how we can make sure that while we're dealing with the opioid epidemic, that we don't make it difficult or impossible for people who need opioids to relieve their pain to get them. Let's start with you, Ms. Steinberg.
Yes, I think the best thing you can do is have the CDC guidelines revised. They really have been taken as law. They have, as the CDC behind them, people think that those are based on strong science, and they're not. So the Pain Management Task Force that Congress did wisely create of pain management experts is producing a report now. And the report specifically reviews the CDC guidelines and makes excellent recommendations on how to revise them. I really think that Congress should ask CDC to revise those guidelines based on the task force report. Dr. Gazelka and I both serve on that task force, and they really need to be revised. CDC are not pain experts, and they did not use pain experts to create those guidelines, sadly.
Mm-hmm. Well, the CDC deals with epidemics, and obviously we had an epidemic, but you're suggesting, I hear your suggestion, and maybe that's a subject for another hearing.
You know what? NIH is the best place to put pain. NIH has an Office of Pain Policy. CDC has no pain section. I've done tons of research on CDC to understand why their attitude towards pain is the way it is. They don't have pain experts. NIH is the place really that should decide those things. They have the Office of Pain Policy. They know about pain research. And I think they're the best people to make a decision like that and to pull the experts together. They've done the best job with the National Pain Strategy and with everything else. I really don't think it belongs in the CDC.
Thank you, Ms. Steinberg, and thank you again for making the effort to come today. Dr. Gazelka.
I think the best thing that could happen with the CDC guidelines is that people understand what they were intended for. They were intended to advise primary care providers. They were not intended to provide hard and fast rules. I actually like the CDC guidelines. At the risk of having tomatoes thrown at me, we use those guidelines to form our chronic pain management guidelines at the Mayo Clinic. I think they have a lot of good advice on how you monitor a patient appropriately when you place them on opioids. The doses that are mentioned probably are not as scientifically based as we would prefer that they would be. But they do not say don't use chronic opioids. They suggest doses where you might kind of yellow light, red light, become concerned with the use. And so those numbers are concerning somewhat. But I think that the basis of the guidelines was sound as far as the intention of them. Mm-hmm. Where the numbers came from is probably more questionable.
Do you see those guidelines as inconsistent with, say, a decision by a Mayo team that for a knee surgery, 16 days of opioids would be appropriate?
Yeah, I think that there's very little mention, as I said, of acute pain management. They were not really intended to address acute pain management as much as chronic pain management. They do suggest that you limit to 3 days or 7 days unless there's a compelling reason to do otherwise. And I think that leaves some room for physician. I think that leaves some room for, for physician.
But that's per prescription, right?
That's correct.
It's not forever.
For acute prescribing, that's right, for a one-time incident or surgery, yeah.
Gotcha.
Not for chronic pain. The guidelines within are different.
And just for the lay person, which most of us are, what's a short description of the difference between chronic and acute pain?
Yeah, so we have considered, in the medical literature, typically 3 months has been used to describe the transition to chronic pain. We've used 45 days at Mayo just to allow our surgeons a shorter time that they would be prescribing. But I think between 45 days and 3 months, anything over that time period is typically considered chronic.
Dr. Cook?
There's not much I can add that hasn't already been added by my learned colleagues, except that it's the law of unintended consequences, and people take these guidelines as law. So we need to reassess them, and we need to remind everyone that they are indeed education and a place to start. That's what we should need to do.
Thank you. Dr. Rahul Patel?
Yes, so I'll just add this comment and say I agree with everything my colleagues have said here. But what I'll say is that the reason that the CDC made these guidelines is part of the reason that we have an opioid epidemic now is because there was a lack of education and knowledge on how to prescribe these medications. So I won't pick on any other specialty but my own. I know they're geared towards primary care physicians, but they can be used for any specialty. And as a physiatrist, I'll say that physiatrists used to write a lot of opioids. We write a lot of opioids. A lot of us are interventional pain management doctors. A lot of us do chronic pain management, which is what I did. So I think that the goal of what the CDC was doing is correct, which is that there were not a lot of guidelines on how to prescribe these medicines. So people would go in to their physicians on Monday morning after having a flare-up of their back because they painted their home, and they would come home with a 30-day prescription of opioids, which is not necessary. So I think the intentions were correct. I think like any other guidelines, they're guidelines. There are going to be people who fall outside of those guidelines, and it's entirely appropriate to prescribe outside of them. I think that's where the universal precautions comes in managing chronic pain and making sure that you're assessing a patient's function, a patient's how they're responding to the pain. Are there any other risk-benefit ratio? Do they have informed consent, et cetera? And I think like any guidelines, they're open for revision. Just because something was written 1 month ago, 3 months ago, 6 months ago, doesn't mean that 6 months from now, the guidelines have not changed. So what I would say is that that they are a revolving door of guidelines. I think there's certainly room to improve them, to change them. But I do understand the reason that they were written, and a lot of that is the reason that we're here today.
Thank you very much. This has been a follow-up to what was the president described as the most important federal law to try to fight a public health epidemic. That was the opioids epidemic. But as I mentioned earlier, this committee, which has, as you can see from the personalities on the committee, has broadly divergent views, generally left to states, physicians, and agencies who write guidelines these decisions about limits on prescriptions, rather than try to write an inflexible federal law that applied everywhere. So there's plenty of room for discussion and adjustment if adjustments need to be made. We welcome any follow-up comments you would like to make, where you can tell by the interest from the senators today that we're very interested in the topic. The hearing record will remain open for 10 days. Members may submit additional information during that time if they would like. Thank you for being here. The committee will stand adjourned.